Hello, everyone. My name is Dr. Robert Arntz. I'm an ER physician and a full-time faculty member at KCU Joplin, and I'm excited today to get to talk to you about point-of-care ultrasound use in primary care.
I hope to accomplish several things with this talk. First, I want to define point-of-care ultrasound testing for you. Next, I want to discuss the advantages and disadvantages of point-of-care ultrasound. Third, I'd like to spend some time discussing the physics of ultrasound and the types of probes available. Next, we will talk about the different applications of point-of-care ultrasound in the primary care setting. We will then discuss the different ultrasounds available for purchase. And finally, we'll discuss the resources available for point-of-care ultrasound education. Why is this talk worth your time and attention? There are several reasons. First, point-of-care ultrasound is better for our patients. It reduces costs, radiation exposure, imaging delays, and increases patient satisfaction. It's also useful in resource-limited settings. And next, the point-of-care ultrasound wave is catching hold in residencies and medical schools across the country. Students are being trained in medical school, and residents are being trained in residency how to use point-of-care ultrasound to take care of their patients. I think point-of-care ultrasound could be a tool that would be great for you in your current practice. And right now, like never before, the tech and the cost is at a price point that both make sense. Over here to the right, we have a picture of my boss, Dr. Paulson, and we have the president of the American Academy of Family Practice, which is Dr. Gary Leroy. And what I'm wanting you to focus on is right here what Dr. Leroy has in his hand, and that is a butterfly IQ. That's an ultrasound, a handheld ultrasound that plugs into your phone. And I have one of these that I keep in my bag and take with me when I go to my shifts in the ER. This unit here sells for about $2,000. So even Dr. Leroy, the president of the American Academy of Family Practice, understands the significance of point-of-care ultrasound testing to family practitioners in the future. Now that we've established that point-of-care ultrasound is worthy of an hour of our time to discuss, why should you listen to me? I'm going to tell you that I have no formal training in ultrasound in residency. I came out in 1996 prior to any of the ultrasound being taught in residencies. I have been a practicing emergency physician for the past 30 years, and I've used point-of-care ultrasound in my practice since 1997. I currently use point-of-care ultrasound for a wide variety of clinical applications, including cardiac, abdominal, MSK, musculoskeletal procedures, and to assess undifferentiated shock. I am an old dog, but I'm here to tell you that as an old dog, that you guys may be as well, you certainly can learn some new tricks. So with that said, let's move forward. Since I've tipped my hand to you that I am an old dog, it seems appropriate that we would talk about the evolution of point-of-care ultrasound. So initially back in the mid-90s, machines were expensive, in the $50,000 to $60,000 range, and they were hardly portable. This is a picture of a machine not unlike the one that I started out on, and this was considered a portable ultrasound machine. Now you can see it's about half the size of a bed. It was like pushing around a small appliance. And it provided poor image quality. You had to have multiple probes. Every time you wanted to examine a different area, you had to plug in a new cartridge with a new probe on it. It was just kind of a hassle. Now here's me with my Butterfly IQ that plugs directly into my iPhone or into an iPad. I can take this with me anywhere in the world. Literally, if I want to do third world medicine and take ultrasound with me, I can put it in my bag and go. This scans directly into my phone, and the image is there. It's captured. I can send it Bluetooth to a server or store it. This ultrasound machine lets me do any type of thing I need that before required multiple probes. This device is relatively cheap. It's around $2,000, and all of the studies can be done, including musculoskeletal, all the way up to deep intra-abdominal structure scanning. It can all be done with a single probe. Let's define what point-of-care ultrasound is. So point of care ultrasound is used much like a stethoscope. In fact, some people have called it the stethoscope of the 21st century. It's used much like a stethoscope. It's a tool to guide treatment of the patient in real time. It is not a formal ultrasound. Okay, so in the past, when you've ordered an ultrasound of the gallbladder and the radiology reads that, and it's done by an ultrasound tech, and you get all these measurements and such, that is not what point of care ultrasound is. Point of care ultrasound is done to answer specific questions. For example, is there a pericardial effusion present? Is there intraperitoneal fluid present? Are there gallstones present? Is there hydronephrosis present? Is there an abscess? It's essentially used as an aid to clinical decision making and assists in the performance of procedures. And it gives real-time feedback at bedside just like a stethoscope would. So I think of these two as tools that I have in my tool bag to help me diagnose patients. Let's take a slide and talk about the pros and cons of point of care ultrasound. So the pros are many and the cons are few, but they are significant. So let's talk about the benefits. Basically, you can use it for both diagnostic and procedural purposes. There is no ionizing radiation. It is non-invasive, portable, easy to use, quick. You get immediate feedback at bedside. It's relatively inexpensive. You can easily repeat exams at bedside, enhancing the ability to track and do serial reassessments of patients. It improves diagnostic accuracy, decreases overall cost of care, and decreases time to diagnosis. And these are research proven benefits. Cons are few, but they are significant. First of all, it is operator dependent. So as you're learning ultrasound, your image quality is poor because you're a poor ultrasonographer. And as you improve with your ultrasonography skills, your images to interpret become much more clear. Limitations, you get poor image quality anytime you're trying to go through fat and or air. So if you have a gassy patient with a lot of bowel gas, that's difficult to get through, and also somebody who's got significant obesity, it's difficult to get a good scan through their subcutaneous tissue. Let's spend some time and talk about ultrasound physics. Briefly, let's go over how an ultrasound works. So the ultrasound probe contains piezoelectric crystals, and an electrical current is passed across them and they vibrate. These cause sound waves. The sound waves go and strike an object, and the sound waves are bounced back. They're picked up by sensors in the probe, and that sound wave is converted into electrical impulses and sent to the microprocessor to create an image. So that's essentially how an ultrasound works. Before we get out of the physics department, we need to talk about frequency and wavelength. Frequency and wavelength are important when we talk about ultrasound because they have a lot to do with what probe is used for what study. So let's get into it here. Frequency refers to the number of times per second a wave is repeated, and wavelength is the distance the wave travels in a single cycle. And the important thing to remember here is that frequency and wavelength are inversely related. So the higher the frequency, the shorter the wavelength. Okay? Now, this is important. Why? Well, it's important because higher frequency sound waves give better resolution on an ultrasound machine. So if you have a probe that has high frequency, you're going to get a good image, okay? But you're not going to be able to go very deeply into tissue because the wavelength is short, okay? A low frequency probe will give you deep penetration into a tissue, but you're going to sacrifice some image quality for that. So high frequency probes, their limitations about down to 6 centimeters. We use these to look at musculoskeletal things and look at vascular access and things close to the skin. Low frequency probes, basically we use to image aortas, deep structures, things like that. And the image quality is less on a low frequency probe, and the image quality is better on a high frequency probe. So that's the importance of frequency and wavelength and why we have different probes for different anatomic studies. Now let's talk about the different types of probes available for the ultrasound machine. There are essentially three. There's a linear or vascular probe, there is a sector, phased array, or cardiac probe, and then there's a curvilinear or abdominal probe. Each probe has a different purpose, and we'll go through that in detail. So first let's talk about the linear or vascular probe. It has a high frequency and therefore short wavelength. That means it has high resolution because its frequency is high. So the structures you image you'll see very well, but because the wavelength is short, it does not penetrate deeply into the body. The maximum you can go with this probe in depth is approximately 6 centimeters, and so we chiefly use it to look at vessels closer to the surface of the skin. The next probe I'd like to talk about is the one to the far right. This is the curvilinear probe. The curvilinear probe is the probe that I use to image structures deep in the abdomen. If I want to look at the aorta, I use the curvilinear probe. If I want to do a fast scan, I typically do use the curvilinear probe. It has great penetration because the wavelength is longer, but the frequency is lower because of the wavelength being longer, so the resolution is less. The last probe is kind of a compromise between the two, and it's called a cardiac probe or a sector or phased array probe. I like this primarily because I can get it between the ribs. The footprint of the probe is small, so it fits between the ribs, and I can image the heart well with it and also look for pleural effusions in the lungs with it. Now we're to the fun part of the talk. This is how am I going to use this in my practice, and I'm just going to kind of share with you how I use it in my practice, and I think a lot of that actually is applicable in primary care as well. So I use ultrasound to look in the chest and the abdomen. I do a fast scan routinely on trauma patients. I'll tell you about that and explain how it's done. I also look for undifferentiated shock with the ultrasound, causes of undifferentiated shock. I look at the heart, the lungs, the aorta, the gallbladder, the kidneys, and look at the bladder for urinary retention. In musculoskeletal, I look and differentiate between abscesses and induration. I assess joints, look sometimes at fractures, assess ligaments and tendons, and rule out foreign bodies. With eyes, I look for retinal detachments and hemorrhage. I also do procedures with the ultrasound machine, including central line placements, peripheral IV placements, and for OBGYN, I look for fetal well-being and fetal heart tones. I do not use the point-of-care ultrasound to rule out ectopic pregnancy. I have never really been trained to the point that I feel comfortable to do that, and so I still get a formal ultrasound done by an ultrasound tech and read by a radiologist to rule out ectopic. Now, there are many of my colleagues that actually go ahead and rule out ectopic with their point-of-care ultrasound, and certainly it's within the capability of the machine to be able to do that. It's just not something that I'm comfortable with at this time. And the same is true of looking for DVTs. Again, this is something that I have not been trained to the point that I'm comfortable doing that with my point-of-care ultrasound. So I order a formal ultrasound to do this. And again, many of my colleagues will go ahead and use their point-of-care ultrasound to rule out DVT and look for arterial occlusion and such. So let's start our practical application of point-of-care ultrasound testing with the FAST scan. The FAST scan is the focused assessment with sonography for trauma. This is the first application I was using the ultrasound, point-of-care ultrasound for, and I started back in 1997. FAST scan started in 1996. And it was a standard set of ultrasound examinations to quickly evaluate blunt and, for that matter, penetrating trauma patients to assess for intraperitoneal hemorrhage. So the whole idea is to look for free fluid, which in the setting of trauma is most likely blood. So we looked at several different places in the chest and abdomen, and we looked in the right upper quadrant. This is the Morrison's pouch view. We looked in the subxiphoid area at the heart. We looked in the left upper quadrant at the spleen and the splenorenal recess. And then we looked around the bladder. The chest ultrasound was not added until later. Okay, and so this is a great screening test for trauma patients, and we will apply this later in the lecture. So that's the FAST scan. This is what I started on. I'm going to show you guys the basics of doing this, and then we'll go over some cases where we're using FAST scan to detect pathology. So the first view I'd like to talk about on the fast scan is the view of Morrison's pouch. This is the hepatorenal view. This is the positioning of the probe here. Basically, you're down at the lower aspect of the rib cage in the mid-axillary line, and you're looking for the liver and the kidney where they come together. This junction of the liver and the kidney is known as Morrison's pouch. This is the most dependent portion of the abdomen when somebody is laying supine, and so it tends to be where blood pools. So this would be a normal look at Morrison's pouch with liver being here, kidney being here, and this is an abnormal view showing intraperitoneal fluid. And this black line here is fluid between the liver and the kidney. So you got liver here, you've got this big white line of scleratus fascia on top of the liver, or on top of the kidney, and then you've got free fluid in between the two in the area known as Morrison's pouch. So this would be a positive fast scan. So the next view I want to talk about in the fast scan is the perisplenic view. That's essentially the left flank. This would be the probe position for that. And here's what normal looks like. Here's spleen, here's kidney, and this is abnormal. This is spleen, this is kidney down here, and all this dark is fluid. That's free fluid around the spleen. This black line coming through here is a shadow caused by a rib. But essentially, so that's free fluid, and that's positive fast scan with fluid around the spleen. The next fast scan view is the subxiphoid view. Here's the position of the probe for that scan. Basically, you put the probe below the xiphoid process and angle toward the scapula and shoulder on the left. This is the view you get, and just for orientation, here's liver, apex of the heart, the right ventricle, the left ventricle, the right atrium, and the left atrium. And what I'm looking for here, first of all, I want to make sure there is no fluid in the pericardial sac, and so I trace around the edge of the heart and where the pericardium is and make sure there's no fluid between the pericardial sac and the heart itself. And then the next thing I do is just get an overall gestalt as far as the contraction of the heart. Is it contracting well? Is the heart getting a good squeeze or not? And I'm not doing a formal ultrasound measuring ejection fraction, etc. So two things here: is there a pericardial effusion or not, and is the heart squeezing well or not? The final view for the fast scan is the pelvic or retrovesicular view. Essentially, we're looking around the bladder, okay? And here's the probe position for that. You want to look in transverse and in longitudinal plane. And so here's a bladder in transverse plane. And what you're chiefly looking for is fluid on the outside of the bladder wall, okay? And this incidentally is kind of where I look to see if somebody has urinary retention as well. So if I have, say, an elderly gentleman with BPH who comes in and is having issues, I'll take a look and see what his post-void volume is in his bladder to see if he's emptying all the way. But for trauma, we're wanting to look for fluid around the bladder, and here is a positive fast scan. So here's the bladder here, and you see this black outside of the bladder, and for ultrasound, black is fluid, and so that's fluid outside of the bladder, and in the circumstance of trauma, that's most likely blood. Now that we've reviewed the basics of the fast scan, let's go through some cases and see how we apply it. So here's an 18-year-old unrestrained driver in a rollover MVC at highway speed, comes in with abdominal and chest pain. Vital signs 115, heart rate, respiratory rates 18, blood pressure 105/80. So relatively stable. Diffuse right-sided chest and abdominal pain. There's no crepitus, no subcutaneous emphysema. So following the ATLS guidelines, we assess airway, breathing, and circulation in that order, and at the end of the circulation evaluation is when I do the fast scan. Okay, so here we go. This is a normal appearing fast scan up here just for review. We have liver, we have kidney, this is the diaphragm coming down here, and there is no fluid in Morrison's pouch, the space between the liver and the kidney. This, on the other hand, is the ultrasound of this patient, and this patient has some fluid in Morrison's pouch right here, this black stuff. So here's liver, here's kidney, and this fluid, this dark in between the liver and the kidney, is fluid in Morrison's pouch. So this is a positive fast scan. Now this is beautiful, especially if you're working in a critical access hospital. You have maybe nobody that wants to do any trauma surgery, if you have a surgeon at all, and you have this patient come in. You can shoot a quick chest x-ray, a pelvis x-ray, maybe your lateral C-spine if you want, and in the meantime, get IV access and get an ultrasound fast scan done. If the fast scan is positive, there is no need to do further workup. You can just call the trauma center and say, hey, I've got this 18-year-old boy here who was in a car accident, and he's got a positive fast. They'll accept that right away, and you can just get him out of your facility, because, you know, remember, time is life when we're talking about trauma and the golden hour. So the quicker we can identify intraperitoneal hemorrhage, the faster we can get them to definitive care. So here's another patient that I've seen who came into one of the trauma centers I worked at via EMS. He's a 21-year-old gang member. He'd been stabbed in the left anterolateral chest. He had a blood pressure of 80 over 40, heart rate of 125, respiratory rate was 30. And a SAT of 92% on 100% normal breather when he got to my facility. It was quickly identified that he had a hemopneumo on the left. Chest tube was placed. He was given a liter of fluid. And on repeat physical exam, his vital signs did not respond as I would have liked. And so, again, airway, breathing, circulation. So I was down to the C portion and had done my assessment. He had no abdominal tenderness, but I went ahead and did a fast scan on him, and here's the subxiphoid view. Reminder, here's the position for the probe for the subxiphoid view, and this is normal, just to keep in mind. Okay, right ventricle, left atrium, left atrium, no fluid in the pericardial sac. Okay, now I'm going to go ahead and see if I can't play this cine loop for you over here. We'll get this going, and I'll pull up my pointer. And what you notice is, see all this black right here? This is fluid in the pericardial sac, okay? And you can see it's actually causing tamponade physiology. His right ventricle is not filling as well as it should. The right atrium is not filling as well as it should. So this basically was the etiology of the patient's hypotension. Again, a big pericardial effusion, which is traumatic in this case. He'd actually lacerated his ventricle. And so he needed pericardiocentesis, a pericardial window, and a cardiothoracic surgeon. But I was able to sort that out pretty quickly from the time he arrived and get the cardiothoracic surgeon on his way to fix this guy. So the next thing I use the ultrasound for a lot in the emergency department is to help me diagnose undifferentiated shock. And there's a protocol called the rush exam. I'm not going to go through the details of that with you, but just think of it as a glorified fast scan, where in addition to the fast scan, you're also looking at the lungs and the aorta and the IVC. Okay. So here's how you use the ultrasound to help you sort out undifferentiated shock. So somebody comes in, they're hypotensive or in shock, and you're wanting to know why. Well, the first thing I do is put the ultrasound on them, and I look at their IVC. Okay, is their IVC engorged or is it flat? If it's engorged, then I go to their heart and look and say, okay, so why, they've got an engorged IVC, so their central venous pressure is up, but their overall blood pressure is down. And so you look and rule out pericardial effusion and tamponade. You look at the global contractility of the heart. If it's bad, then it's probably cardiogenic shock. And then the other thing I look at is the size of the right side of the heart. If you have an engorged right atrium and right ventricle, then it's concerning for possible PE. Okay. Now, on the other hand, if I look at the IVC and it's flat, then that can be due to several things. It could be hypovolemia secondary to dehydration or bleeding. It also could be sepsis, causing decreased systemic peripheral vascular resistance. And it also could be some sort of drug overdose. And so very quickly I can get an idea on a patient that can't give me any history that is in shock. And so with that said, come on over here. This is a view of the IVC, and this is right here. This arrow shows where the hepatic vein dumps in. This is the right atrium over here, and this is liver up here. And this is what a normal IVC looks like in terms of volume. Here's somebody with a flat IVC, okay? And this might be somebody they're hypovolemic. We don't know why. It could be due to, well, their central venous pressure is low, so it could be hypovolemia, or it could be decreased systemic vascular resistance, one of the two, okay? We don't know which, but we know that their IVC is flat, okay? Heart again, liver, IVC, and there you have it. So that's a little bit of background on the use of the rush exam for diagnosing undifferentiated shock. I included this case to show you how we use the ultrasound to help us determine the etiology of undifferentiated shock. So here is a patient I saw recently, and this is the actual ultrasound I did on her. This is a 72-year-old female with past medical history significant for coronary disease, hypertension, mild fever. She comes in with hypotension and multiple syncopal episodes. And part of the workup I did on her was to just do the modified rush protocol that I was showing you in the previous slide, but I'm just going to show you the IVC portion of this. So when somebody comes in, they have undifferentiated shock, and they have limited ability to give you a history. You can certainly just go to this rush protocol and take a look. And so what you do, you look at their heart, you look at the contractility, you look at the IVC and the degree to which it's filled, and then you do a fast scan and some other scans of the aorta, etc., and try to get the etiology of the shock. And so in this instance, this is the IVC portion. If you look here, I'm pointing out the IVC. There's the right atrium, the IVC coming off here. If you compare this IVC here to this normal IVC over here, you can see that it's flat. Okay, so she has a low central venous pressure. Okay, this would be what a normal IVC looks like over here. And what we do, we measure the IVC where it comes into the heart, and you can find that by finding the hepatic vein and where it dumps into the IVC. So here's liver, hepatic vein, IVC, right atrium, and so this is a normal appearing IVC. It's full of blood. And then when you compare it with this lady's over here, hers is relatively flat. Okay, and so that tells me what? That tells me your central venous pressure is low. Now, I don't know the etiology of why your central venous pressure is low, but typically if the heart has a good squeeze, there's no evidence of tamponade, and the central venous pressure is, or the IVC is low, then you think about things that would cause that. Decreased volume from blood loss or dehydration, or decreased systemic vascular resistance from overdose of medications or over medication of blood pressure medicines, or from possible sepsis. And in this lady, she actually had a urinary tract infection and was mildly septic secondary to that, and mildly dehydrated as well. So that was the etiology of the shock, and that's how we use it, much like a stethoscope, to help us determine the cause of the patient's shock. Now let's take a look at some applications outside the hospital setting. So here's a patient I saw recently, 54 years old. She's got a history of MRSA and diabetes, and she comes in with a sore in her back for the last 4 days. And here's a close-up view of that. And you know, MRSA is the scourge of the earth. I don't have to tell you that. I hate this stuff, and I especially hate these types of MRSA infections. So when you feel this lady, it's hard, it's indurated, you don't know if there's pus underneath there, if it's coalesced yet or not. And so I'm about 50-50 on these. Sometimes I'll cut them open and there's pus there, and sometimes I cut somebody open and there's no pus there. But here's the ultrasound I did on this person, which proves that she actually has a coalesced abscess. Okay, and so I know when I cut into this that I'm going to get an abscess, okay, and get some pus out of there. Now, the other thing I can do if I'm apprehensive, I mean, this is pretty straightforward, just going to cut kind of right across the top of that thing to get in there. But let's say I'm concerned, or it may be a deep abscess, I can take the ultrasound and I can guide the needle down into the abscess cavity, even aspirate it if I wish, and I can follow the needle with my 11 blade to get into the abscess and go straight in. So I can not only diagnose the abscess, but I can do an ultrasound guided IND if I choose to. So this is a nice practical application. This patient I did see in the emergency room, but this could be an office patient just as easily. So here's another very practical application of the ultrasound. So this is actually a case of a friend of mine. It's a 24-year-old black male who was playing basketball and went up for a shot and felt a pop. And I'm going to tell you that pretty much I knew what was wrong with him. I mean, he had pain over his Achilles, and when I did a Thompson test on him, it was positive. So I knew he had ruptured his Achilles tendon. But here's the issue. He didn't have any insurance and didn't want an MRI bill or anything like that. And so I just used the ultrasound to diagnose him with a ruptured Achilles tendon. And so this is my wife's Achilles. Actually, I did this to kind of just show you what a normal Achilles tendon looks like. And tendons have this kind of fibrous look to them. So here's her normal Achilles. Now, this is not the actual ultrasound of my friend's, but his look very similar to this. Here's the Achilles coming along here. And then you see there's disruption right here. So I was able to basically take this with my little pocket handheld unit and send that to the orthopedic surgeon that was going to see him, and he went ahead and scheduled surgery and did the operation on him without the patient ever having had an MRI or any of the usual diagnostic testing that was needed. Now, all this dark here is blood. And this there's a little kind of some floaties around in here. It's probably coagulated blood, but right there you can see the clear disruption of the Achilles tendon. So here's a ruptured Achilles diagnosed with point-of-care ultrasound. This is actually one of my favorite point-of-care ultrasound slides. This is the first point-of-care ultrasound done by a KCU student on an actual patient. And so the story here, this is a 47-year-old female who came to the community clinic for establishing care. That's a clinic in our town that takes care of the indigent population, the folks that do not qualify for Medicaid and don't have access to care. Can come there and get care for free. So we take our students down there. The students get good experience taking care of the patients, and the patients get good care. So it's a win-win for everyone. This lady had a history of hypertension. She was on lisinopril. Her blood pressure was poorly controlled. She still smoked. There was a vague family history, she said. She's not sure who had it, but somebody had something polycystic. Didn't know if it was kidneys, ovaries, or what. She'd never been diagnosed with it. And so during the process of her workup, we found that her creatinine was elevated at 1.8, her GFR was 35. And so one of my students said, hey, would it be okay if I did a scan on her? And so normal is over here, and this is what he found. So here's liver, here's kidney, and you can see all the cystic structures in the kidney. Compare this kidney to what it should look like over here, and you can see that this patient has polycystic kidney disease. And so, our student, medical student, first-year medical student with minimal training, less than probably an hour on the ultrasound machine with instruction and hands-on experience, was able to go in and do a fast scan and look at this patient's kidney and see that it was not normal, and she indeed had polycystic kidney disease. So this is important for a couple of reasons. First of all, it helped us guide what type of blood pressure medicine that was best for her in light of her polycystic kidney disease and renal insufficiency. And we did this without even having to do a formal ultrasound. So there was a significant cost benefit there as well. Great case and great illustration of the practicality of point-of-care ultrasound. So here's another great example of the application of point-of-care ultrasound. This is a 35-year-old male who presents with central vision loss in the right eye. He's able to see hand motion in the right eye, but nothing else. The left eye visual acuity is normal. He's had no trauma, no foreign body sensation or headache, and this has been going on for about 3 days. Classic ER. You don't have vision in your right eye, so you wait for 3 days until you come. Anyway. Having said that, this is a great application of point-of-care ultrasound to look at eyes. And so let's just kind of review normal anatomy here. So here's eyelid, cornea, anterior chamber, the iris, the lens, vitreous, and retina. And this is the optic sheath, this dark acoustic shadow here is caused by the optic sheath, okay? And so this is just a quick ultrasound I did on my wife at home. Normally when I look at the eyes, I take some Tegaderm and put over the, have the patient close their eye and put it over their eyelid, and then just fill their eye socket with ultrasound jelly. I didn't have that at my house, so I just took some Glad wrap that we used to, like wrap sandwiches in or whatever, and put it over my wife's eye, and then basically gooped her eye socket up. And so this is a suboptimal scan, but I just wanted to show that it can be done fairly simply. And so you can't really see the anterior chamber stuff because I've got the depth set to 4 centimeters. If I dropped it down to 2 centimeters, you could focus up here on the lens, the anterior chamber and eyelid and stuff. But I was more interested in the retina. And so here's retina coming along here, and there's the optic sheath for her. Now, here's the patient that we talked about here with the visual loss. And what you see here basically is it kind of this wormy looking stuff here, and that's actually what a detached retina looks like. So this patient has a detached retina diagnosed with the ultrasound machine. I can tell you one of the things that's frustrating in the emergency department a lot of times is try to look at the back of somebody's eye. Many times you're not dilating them, but yet you're trying to look at their retina and stuff. And so in this case, I can basically screen somebody pretty quickly for a detached retina just with the ultrasound machine. So again, another practical application that's also kind of fun. So here's another very cool application of point of care ultrasound. This is a 54-year-old male, comes in with chronic right knee pain, which is increased recently with pain and swelling. And so once again, my poor wife, here's just a brief ultrasound of her distal femoral condyle. So this would be the head, there's the feet, and this is her femur coming along right here, the femoral condyle coming up and over, and then this right here is patellar tendon over the top of it, okay? And notice there's no fluid within the joint space itself, no appreciable fluid, okay? So this gentleman, his knee was swollen, it was not hot. I did not suspect a septic arthritis, but I was concerned about a joint effusion, and so we'll take a quick look at his knee here, and here's his femoral condyle coming along here, and see all this black in here, all this black right there. So that is fluid within his joint. There's a little bursa there, but here's his femoral condyle, and there's his patellar tendon right there coming along, okay? And so anyway, yeah, he's got a lot of fluid in his knee joint. So if you did need to do a tap, you could do it with ultrasound, but you could check before and make sure there's a lot of fluid there, and you could do it blind if you wanted. Now here is basically, this is a distal end of his femur, and here comes his tibia into view down here. So this is the tibia coming in down here. And again, patellar tendon tracking along there. So pretty cool illustration of a joint effusion on ultrasound. So here's a 40-year-old obese female coming in, has right upper quadrant pain after eating greasy food. You're concerned that it may be her gallbladder. Again, I take a look at the gallbladder with my ultrasound. I differentiate that from a formal ultrasound of the gallbladder. So again, I use it for a diagnostic purpose. If I see a stone, then I kind of know what's going on. If I don't, I may still go ahead and have them sent for a formal gallbladder ultrasound to measure the cystic duct and all those types of things, and the wall of the gallbladder. But once again, this is one of those deals, the more you use it, the better you get at reading things. And so I'm pretty comfortable looking at gallbladders, and so let's just take a look at this one real quick, and it gives us some findings here that are kind of nice to talk about. So first of all, remember the ultrasound is coming from the top. Ultrasound wave is coming from the top end of the screen and going down, and this right here is a stone in the neck of the gallbladder. This structure here is the gallbladder. Here's a stone in the neck of the gallbladder, and there's kidney underneath here. But basically, this is a stone. It's hyperechoic, meaning that it bounces sound waves back. So it's bright on the front side where the ultrasound waves hit, but there's a shadow behind it because no ultrasound waves pass through. So it's an acoustic shadow is what that's called, and so that's how you know this gallstone here. And then if you look at the gallbladder wall, it's thin. I don't see any thickening of the gallbladder wall. That's just a gestalt on my part. And then this right here is sludge present in the dependent portion of gallbladder, and there's no pericholecystic fluid. So, again, ultrasound, great for imaging the gallbladder. Point of care ultrasound, I use it to image the gallbladder, but I do not consider it a formal gallbladder ultrasound study. So here's another case I saw recently in the ER. It's a 22-year-old male who comes in with possible back and abdominal pain. It's hard to say. He has a history of CP, MR. He's nonverbal. He comes in from a group home. Going through his sheet, they mentioned that he'd had some kidney problems, but this was a laundry list of past medical history. I'm sure you've all had experience taking care of these types of patients. They're nonverbal. They typically come with a care provider who's got a big notebook full of stuff that's basically everything that patient's entire medical history forever. And they really don't know what's going on, just know that the patient seems to be hurting. And so with the history of the kidney problems, I thought, I'll take a stab and maybe take a quick look and see what's going on. So just to go over anatomy here, this is what a normal kidney would look like. Your renal pelvis is here. You have the medulla, gratis fascia over the top. There's renal cortex there in the calyces. Okay, and here was this kid's ultrasound. Okay, and take a look here. He's got a widely dilated collecting system. This is his renal cortex up here. See how it's all kind of mashed out, and then there is a very dilated ureter. So he's got hydronephrosis. Now who knows the cause? Could it be a big stone, or does he have some sort of ureteral stricture or something weird going on? It's hard to say, but his pain is basically from renal colic. So that was a nice ability to just take a quick look at that. I'm going to finish out the practical application of the point of care ultrasound, like how you'd use it in the office, by talking a little bit about aortic imaging and aortic pathology. So here's a cross-sectional view of what the normal aorta and vena cava would look like. And so here, right back here, is a vertebral body. See how it's hyperechoic on the front, and then there's this shadow behind. So that's vertebral body. This is the aorta. It's nice and round, and the inferior vena cava is to the side and kind of collapsed. Okay, so here's a case I saw back in the day, and this is not his actual image because I didn't save his actual image, but it was very similar to this one. So this was an elderly male I saw probably 15 years ago, and I'll never forget the case. He came in, he was kind of a stoic farmer guy. I'm sure you guys see these folks frequently in your practice. And I asked him what was wrong. He said, I had some back pain while I was loading my mower into the back of my pickup truck. And I'm like, okay, you're 74 years old, you're lifting your mower in your pickup truck, it's probably DJD, or you've strained or sprained something. And so I got a plain film of his back, and it certainly showed decreased disc height and some sclerotic changes. And so I'm biting on the degenerative changes and maybe some muscle strain, and he had pain back there. And I was writing his chart up, getting him to be discharged, and I looked up, and as the nurse stood him up to get his clothes on, he became diaphoretic and almost passed out. And I'm like, oh no. And so I went trucking in there. I'm like, sir, go ahead and lay back down for me. And I put the ultrasound on him, and I saw something that looked very much like this. Okay, and so this is aorta in the cross-sectional view as compared to like this normal appearing aorta. Here is this aorta, and the diameter is actually from here all the way over to here. This is true lumen. This is the lumen, and all this is kind of fibrin, clot, debris, and stuff in the aorta itself. But he had a big aneurysm that was leaking retroperitoneally, and so rather than him being discharged home to work on his farm, he ended up going to the surgery to have his aorta fixed. And here is the last case I'm going to leave you with before we kind of close up the talk. But this is a gentleman that I saw. He was 64 years old. He'd been cathed at an outlying facility, and basically was not doing well. He was in their ICU and subsequently was transferred to our tertiary referral center. And I wasn't even supposed to be involved in this case. It was dark 100, about 2-3 a.m. in the morning. I remember it well, and I was kind of sitting there at the desk, and the medics are coming through the ER with this transfer, and he was a direct admit to cardiology, and they said, hey doc, he's just not acting right, he doesn't look good. And I'm like, okay, it's one of those things. It's like, am I in for a penny, in for a pound? I didn't really want to get involved, but at the same time, what do? You do things right for the patient. And so I said, well, okay, wheel him in over here and I'll kind of look him over. And so this guy was on a heparin drip for unstable angina and had been so for 5 days. And so I put the ultrasound on him, and here's his aorta, and look at this line right here, okay? That is not normal, okay? And so then in longitudinal view, here's what we've got. And so this man had an aortic dissection, and so you can imagine the conversation I had with the attending cardiologist at 3 in the morning. He's like, well, how do you know he's got an aortic dissection? I'm like, because I'm sitting here looking at it on the ultrasound machine. And so, he gets he's like, okay, so he throws some clothes on to come in, and I called the CV surgeon, and they wanted a formal ultrasound, because this was back in the day before they thought doctors could actually do ultrasounds, and so sure enough, the formal ultrasound was done, and here's this guy with a big dissection on heparin. And so again, he goes to the operating room. So that's the last aortic case I have for you, and we'll just move on now to the types of ultrasounds available. So I just wanted to kind of go over the types of machines that are out there and what's available. And this changes almost on a daily basis. There's a lot of small players coming into the mix now with pretty good machines that are pretty reasonably priced. I'm not married to any one machine. I have a Butterfly and I like it. But I'm going to be honest with you, the reason I bought it, it was the cheapest ultrasound that I could get that had the technical ability to do what I wanted. And so this machine is relatively new. Everything is housed in one probe, so there's not multiple probes. And the way you are able to scan different things, it alternates the frequency here. So it has a bunch of preset things on it. So like if I want to scan the aorta, I just go to the preset and pick aorta, or if I want a fast scan, I do that. And so this is the image literally off of somebody's phone, and that's the way it is when I scan. I can also scan it to an iPad, and I can see the image on iPad. But the reason I got into this machine was because it was $2,000. That was my cost outlay. And so I'm like, okay, I want to kind of put my finger in the water of this handheld ultrasound business. And so for $2,000, I'm like, I can write part of that off on my corporation, and so sure, I'll go ahead and buy one. Now, where they get you on this is there's an annual subscription fee that's about $325, $350. So you pay $2,000 up front, but then they keep doing software updates, which are necessary. But for that subscription and all their bells and whistles, their training that's pushed to you on your device and all the those types of things, it's like 325, 350, somewhere in there. And so that's the price of the Butterfly. The other most prominent handheld machine is Lumify, okay, and that's a Philips product, and they have multiple probes. And so the image quality is fairly comparable, but the price point is a little bit higher. They're about $8,000, okay. And then GE still has a product out. It's called the V-Scan. We have some old V-Scans at the school. They're great for abdominal imaging, but they don't offer the same broad range of application, because the product that we have, you can't do MSK because it won't scan any more shallow than like 6 centimeters or so. And so our old V-scans are confined to abdominal and heart, but the new V-scan product, I think, probably will allow you to do things close to the surface of the skin. And in fact, that looks like there's doing some sort of vascular thing, so that would be a close to the surface of the skin type of study. Now, this is what I use in the ER. This is the Mac Daddy, okay? These machines, when they first came out, were selling for about 50 grand, 60 grand, somewhere in there. And now you can see how their price points dropped, okay? So these machines, it's kind of like computers. They're continually improving them, and the price points keeps dropping. And the quality is getting to the point where the cost and what you can do with it actually makes sense. This slide is meant to be a slide of encouragement. This is my first year military medicine class This is Dr. Ken Stewart. He's my colleague. He and I teach point of care ultrasound at the KCU Joplin campus. And this is our first year military medicine class. And so we've just given them a quick instruction on how to do the fast scan. And literally, it's about 15 minutes of instruction. And now we're going to watch them perform fast scans. Okay, so here's a GE V-scan. It's an older unit, and we're getting a look at the splenorenal recess here. Again, this is done by a first-year medical student after about 15 minutes of instruction. There's liver, there's kidney underneath it. So nice image there. And then here's a subxiphoid view of the heart. Again, this is done with a butterfly IQ. But again, first-year medical students with about 15 minutes of instruction. So you can do it. The skill is not that difficult. The learning curve is steep, but certainly, I didn't have any formal training when I came out of residency and figured out how to do it. You guys can do that as well. And I do believe it would be a great asset to your practices. So on this last slide, I would just like to acknowledge some of the sites that I used and some of their images. I mentioned before how readily available point of care ultrasound training is, and this is a site that's kind of a grab bag for everything. It's the Society for Point of Care Ultrasound, and it'll give you all the FOMED, free open access medical education sites you can go to. A couple of these are right here. Everyday Ultrasound is an excellent site. Some of the images we looked at today were off of this site. I think that retinal detachment was from there. And then GrepMed is another place where people tend to post point of care ultrasound images for you to use freely. So great resources. Thanks for your attention.